At this time, I would like to introduce our speaker, Cami Sayaseng. And Cami is coming to us from California, where she received her Bachelor of Science in Nursing degree in 1994 and her MSN in 2000 from California State University in Fresno. She's also received her Doctor of Nursing Practice in 2012 from the University of San Francisco. She's been a PNP for about 16 years, with 15 of those years practicing in pediatric dermatology. Currently working full-time as an assistant professor at Fresno State University School of Nursing, she's also working part-time at a local community children's health center. Welcome, Cami.
Thank you. Good afternoon, guys. Can you hear me okay? How many of you have gone to those other dermatology talks that we've had so far? Okay. So I'm going to forewarn you right now, there's a couple of things that you'll see or hear me say a little bit differently than what was said before. And I'll tell you my reasons as well. As Kristen pointed out, I am a PNP. I've been working in the outpatient clinic for about close to 16 years, maybe 16 years, actually. Before we actually have dermatologists that comes to our clinic, we used to have to do tailored dermatology. You guys know what that is, right? We take the pictures, consult, send it through the electronic medical record, and send it to consult with dermatologists outside of our clinics. So I used to do that as well before we actually have any dermatologists coming to us. As all of you probably know, it's very, very difficult to get our pediatric populations into dermatologists, to see a dermatologist, period. And worse yet, to see somebody who doesn't have insurance. The type of patients that I work with are the people that don't have insurance, uninsured children. Medi-Cal, in our California, we say Medi-Cal or Medicaid compared to yours. So dermatologists in our clinic, our wait list is about 6 to 9 months. 6 months to 9 months to see us. So sometimes the patient's conditions already, by the time they get to us, they've already dissolved, they got better on their own. For that matter, because of the wait list, the long time to get into dermatology, I thought, well, it would be a good idea to say some of the things that I see so that other people can take a chance to treat this outside before they get to dermatology or during the time they wait for dermatology. So my clinic is affiliated with University of San Francisco, Fresno Pediatric Residency, so I do work with the residents as well. I don't have any disclosures other than I do want to add one thing to my disclosure. It's not an actual disclosure, but if you look up the AAD, American Academy of Dermatology, all the recommendations and guidelines, they'll say that adhering to all of the treatment recommendations and preventative measures that we recommend or that I will be putting on for you doesn't guarantee a successful treatment in every situation. That's just because every situation is different, every patient is different as well. And no, I'm not sponsored by any companies. So hopefully by the time you get out of here, that you'll we're able to introduce you to some of the common dermatological disorders in pediatrics, recognize them, and then able to treat and recommend the treatments and or sorry. You have to forgive me if my words come out jumble mumble. We were just talking about this. I came from California, West Coast, and so last night, I usually can't take coffee after my 1 or 2 p.m., but I had iced tea last night after 8 p.m. and boy, I was still awake at 3 in the morning. So I couldn't function this morning. I was trying to sneak out and catch some nap cats, but I can't do it. So it just winds me up and then sleep deprived. So sorry about that. Just let me know if I don't make sense to you. But sometimes I question, what did I just say? But just brain fart. Anyway, so hopefully you'll be able to recommend and treat common conditions that I discussed with you here and recognize when to refer the patients to dermatology. I just pick a few that I see that you guys, as general practitioners, you could see and treat them in your office if you have the means to, and I'll point out the means to as well, without referring and inundating those, clog up the pipeline and wait 6 to 9 months for your dermatology referral. So just a little simple anatomy of the our skin first. You have the epidermis at the top, dermis, and the fatty tissues on the bottom. I'm going to point your attention to the top layers. You probably can't see too well on your screen there, but just look at just how busy those skin layers there are in there. In the epidermis, you have 5 layers that I want to bring to your attention. You have the stratum corneum, the stratum lucidum, stratum granulosum, and stratum spinosum, and stratum basale. So stratum corneum is your outermost of the epidermis. And I didn't put those other slides explaining each one of them to you guys on the handout, but basically stratum corneum is your outermost layer of the 5 layers that I had just said there. It's responsible for vital barrier function of the skin. It's made of dead, flat keratinocytes that shade out every 2 weeks or so. Think of keratinocytes as strengthening proteins that help strengthen our skin there. And then your stratum lucidum is found in your palms of the hands and the soles of your feet, those thick areas only. And then stratum granulosum contains more keratinocytes moving towards the surface. So think of the 5 layers of the skin that I just told you about. From the bottom, the basale is going to push up the dead skin towards the stratum corneum to the top. Stratum spinolosum, known as the squamous cell layer, this is the thickest of the layer of the epidermis. This one has the newly formed keratinocytes. It also has the Langerhans cells. These cells help prevent infections. And it aids in the flexibility of the skin to better withstand the effects of the friction and abrasion to the skin. And then stratum basale is the basal cell layer. This one pushes the dead cells up towards the top. And then, so just to let you know, I wish I could put my patients' pictures, but wasn't too sure of the copywritings and all that stuff. I do get permissions from them when I take their pictures. But these pictures, just so you know, I retrieve them all from Google Image. You've all seen this picture, right? Your patients, pediatric patients, too commonly. In the infants, you're going to see them in the face, mostly all over, but you'll see them in the face, upper chest, the trunk, and the extremities quite a bit. As they get a little bit older, you'll see them in the wrist areas, the ankles, popliteals, of course, as well, those flexor folds and all that. Older children, you see them in those flexor and extensor surfaces. Now, with atopic derm, if you look at so many resources, they'll probably say 5 to 20% of the children worldwide are affected. Others say maybe up to about 25, even some resources. In the States, about 17% get affected, and usually before the age of 5. And usually more female than males, for whatever reason that is. Yeah. One of the things that I'm going to point out to you right now is I did go to a couple of the dermatology talks. For those of you that if I don't mean to insult anybody and I don't want to step on anybody's toes, but this is coming from the practice, my practice and experience that I've had is one of the, I think, previous talks was think of milk, cow's milk protein as your trigger or your allergen for patients that have atopic derm. And you'll see down the line that I have cited some studies that had pool randomized controls on those. and they take out the milk and the eggs and some dust mites and all that stuff, and it didn't make any difference on the children's atopic derm condition, but we'll talk about that in a little bit. But just so you know, atopic dermatitis, if you ask your patient's parents, what does your, what did your doctor say you have, or what did the dermatologist say your child has, they'll say, if you say, did they say atopic dermatitis, they'll look at you like, what did you say? No, right? So dermatitis or eczema interchangeably used. So you'll hear sometimes referred to as atopic eczema. But you can, if you say just eczema to the patient's parents, that's what they know more of. It's a genetic defect in the protein supporting the epidermal barrier and the outside layer of the skin again. Chronic inflammatory skin condition. This is not something that just took place a few days ago. There are some studies that try to discredit the triad of atopies, but there's going to need to be more studies on that part, because studies that have come up with that, there's only a couple that I've come through, and the study numbers are not as big to be able to say, yeah, that's the case. But if you look at your patient's history, if you ask those that come in with atopic derm, you're going to see a lot of family history of atopic derm itself, as well as asthmas and allergic rhinitis, right? So keep that in mind as well. As more studies come out, maybe we can say one way or the other, but at this point, it's still the triad of atopy still kind of applies there. It's an impaired epidermal barrier function. It's an immune function disorder. So it's not just that there's some, the skin is, something's wrong with that skin there. It's a disease evolving from the outside in, intrinsic structural and functional abnormalities. The primary defect is your epidermal layer there. Remember, the epidermal is your barrier against the other stuff that's going to trigger your insults to the skin. So it's a first line of defense between the body and the environment. So if you have an intact skin, of course nothing, no irritants or triggers is going to be able to cut through and make your skin get bad. I didn't put diagnosis of atopic derm in there, but you all probably can recognize it if you see it. But the key words that you would see or you would describe atopic derm is your components. You have the dry, scaly, the word scaly. Sometimes if it's been a chronic condition long enough, you can have lichenification or thickened of the skin. Some people refer to it as cirrhosis. So those are your keywords. The other thing also, and I'll talk to you guys a little bit more at the end, when you do the referral, somebody said earlier that pictures don't really do a whole lot. We do get a lot of pictures sent to us and ask for our opinion on those as well. So, I mean, it's better than that, but also your description when you do the referral to us will help us determine if you use correctly the terms, right? So you know the basic terms of this 1 centimeter rule, right? 1 centimeter flat macule. 1 centimeter or less raised is your papule, and then so on and on and all that stuff. So describe the lesions to us. Now, when I was doing derm, the very first of the beginning of my career with derm, one of my dermatologists, and I've worked with a few in the past, I happened to say, you know how we try to be fancy and try to describe our term, the lesions, like in a fancy name. I'm like, what's that spot called, that little spot? And she heard me, she said, Cami, you didn't go through all that schooling to call a lesion a spot. So from there on, I never call a lesion a spot again. But the other thing also is, I want to point out also is nursing, we always call a lesion maculopapular lesion. How many of you have used that or heard that word? Yeah. So and the other thing also is if you look into the nursing textbooks and stuff, you will still see it called that way. But in dermatology, there is no such lesion as maculopapular lesion. So if you don't take anything away from this, there is no maculopapular lesion. You can say there are some macules and papules, okay? But one lesion cannot be both macule and papule, okay? So somebody asked me, well, but if we say that word, you would know what we're trying to say, right? Well, it depends, right? Because if you write it hyphenated, then I don't know what you mean because there's no such lesion. But if you say macules and papules, then yes, I can see what you're trying to say. So our goals of treatment, I think I missed that. Goals of treatments is to reduce symptoms of pruritus and dermatitis, prevent exacerbations, and minimize therapeutic risk. This is the other one that I see the difference when I was hearing from the other talks is the antihistamine has no role in atopic derm. If you have a child, and most of my nieces and nephews have atopic derm, and if you haven't had any children that suffer from atopic derm, severe atopic derm, you don't know how bad that is in the family. It's like you have to treat the whole family as well. So in our clinic-wise, we will treat the pruritus as well, but you know that the hydration and the moisturization is going to help calm the pruritus, right? So you want to stress that fact home. But for them to be able to sleep at night, we give them some antihistamine to get them some sleep at night so the parents can sleep as well, right? So there is some, not in a role that will say, yes, it'll help stop this or stop that, but you know, minimal is to help them get some sleep as well. So again, with atopic derm, prevention is the best treatment. You don't want it to get too bad to the point where that picture of that first baby there, it's going to be really hard to get it to calm down again. So you want to stress home the importance of home care. Mild soaps, we've always known that one, nothing antibacterial, moisturizers and emollients, and I'll talk a little bit more about what the difference between emollients and the moisturizers are as well. Now, topical steroids, in the general practice, a lot of people are afraid to start up the high dose, high strength of it. There's nothing wrong with looking at your patient's condition first. How bad is that, that eczema or atopic derm? Is it severe? Is it mild? Is it moderate? So with dermatology-wise, by the time the patient gets to us, if they didn't self-resolve or didn't get better already with all the recommendations that you've done to them, is we'll go ahead and slam them with the higher strength of the topical steroid. But, you know, if I was to see the patients myself and I know, well, okay, that's not too bad, I'll go ahead and start with the lower strength to it. So topical steroids go from 1 to 7 grade, right? The lowest, smaller number, the higher the more potent the steroids are. So your regular hydrocortisones are like the level 1, and then your hydrocortisone is 7. So like clobetasol and betamethasone would be your level 1 of those. And then in between would be something like triamcinolone and all that stuff would be like level 2 and 3. So you could use those as well. So use the low strength in the thin skin areas, face, axilla, genitalia areas. And ointments, avoid ointments in the folds because the ointments, they get absorbed a lot better. They stay better in the areas. So you don't want it in the thin skins areas. And some people say, well, what's the difference between ointment and creams? If you have the outside areas, the fat surfaces areas, if you wanted to get to really absorb it, you can use the ointment type base. And there is a reason with the 2 weeks of continuous use, you can, if you are, again, in the dermatology clinic already, we use it way longer than that. So that's why I put with some exceptions on there. The other thing also is if you know your patient's families. So if you know that somebody is compliant, and you can tell them stop after so-and-so gets better. When the flare-up gets better, you can go on for another few days or so, but use it once a day or so. And that will still be okay so that it prevents a flare-up as well. Now, is there a difference between using it BID and Q-day? probably so much more of the strength that you're using as well. If you use the stronger strength, you can use it once a day. And again, use with cautions, as you all know already, probably with the topical steroid use. Because it is steroid, you can have problem with purpura, telangiectasia, striae, focal hypertrichosis, where the hair grows from the point that was treated, and then acneiform or rosacea-like eruptions. The biggest concern with topical steroid use is your skin atrophy. So if you have parents that are non-compliant, you give them, you say, you know, they always with us, we always get this that goes, you know, we are given this steroid, and they remember the word steroids. We want that again. And they'll use it, and it's supposed to be done and gone with, but no, they keep wanting a refill and refill because it helps, and they can see that, you know, it gets better pretty fast depending on the strength as well, so they want that quick fix. But topical steroid could be just kind of like a Band-Aid over the cause of the thing. So again, your main point is going to be the drive home the supportive care. So again, that was in the controversial talk a little bit there on the role of antihistamine. So in dermatology, my clinic-wise, we still use it to help with sleep and also with some itching. The thing is, it makes them drowsy, so we try to use, sometimes we tend to use hydroxyzine, less drowsy during the day, and then Benadryl at night just to help them go to sleep. Now, to the really severe cases of atopic derm, where they really, really itch and the parents are really complaining and they can't sleep and all that stuff, my dermatologists have used SSRI like doxepin. But I don't use that myself because that's it's like antidepressant kind of like medication, but at a low dose and with monitoring. But I don't do that, so. But again, a lot of dermatology medications are off-label use, so. Moisturizers and emollients, so use them interchangeably. And emollients is to soften or reduce the water loss from the epidermis. Moisturizer is to add moisture into the skin. So there's a little bit of a difference to it. But both of the emollients and your moisturizers have two actions in common. One, it being occlusive. It provides a layer of the oil on the surface to slow the water loss from the skin, and thereby increasing moisture to the stratum corneum, the one that's giving a lot of people the problems. And also, it has the humectants, which is the substance that is introduced into the stratum corneum to increase water holding capacity. So with atopic derm or eczema, the problem happens because the water doesn't get stuck into the skin. The water doesn't stay onto the skin. So that's why your skin gets so dry. And so you have that water loss to the skin. You can't control that there. So with these two emollients and moisturizers, it's going to help keep trap the water into the skin. Causes of hypersensitivity or reactions to the treatment hindering AD improvement or atopic derm AD. So if you have somebody who you've been treating and why are they not getting better, look into some of the things they're using. Now, of all these years in dermatology, I have one patient that I know of that was reactive to Vaseline, petroleum jelly. So linoleum, you know, I'm thinking like Vaseline is so safe and cheap that, you know, we always say go to Vaseline first if that's not the case, that they don't mind the baby being too greasy. But one baby broke down because of the ointment base, the lanolin base. It might have also propylene glycol and ethylene diamine and formaldehyde for whatever reason. So some of those ointments, topical emollients, might have those in there. So if you can teach your parents to read those labels, you can show them, see what might be the trigger for the cause there as well. Topical immunosuppressive medicines, of course, our topical steroids, calcineurin inhibitors. There was some debates on this. if you're outside of dermatology, a lot of people don't prescribe it anymore, but dermatologists will still use this. It's got a black box warning on it because there were 2 deaths reported, but then they were, if you look at it, if you look from the dermatology perspective-wise, they said those 2 deaths were not exactly related to just calcineurin inhibitor use. The people had some other underlying causes of their health as well contributing to it, but that wasn't looked into it. But so black box was put onto it. But in dermatology, if we need to, we will probably authorize and try to get it covered for the patient for us if we need to. Again, food and environmental triggers. Weston and Howie 2015, the study was in 2015. They looked at eliminating and I forgot to put down the number of the subjects in the study there, but they looked at this study of eliminating environmental factors such as reduction of house dust mite antigens, milk and egg exclusion. They didn't see any difference or improvement in the patient's atopic derm conditions. So they did, sorry, that was a systemic review of 9 randomized trials. They looked at those studies, didn't find any difference into those. I know one of our lecturers had said milk into that and eggs, all that stuff. What you can see also is just look and see what might be this person's treatment might not apply to the others. And you all know that you can't really do the allergy panel testing until there's so many months old. If you do them too early, other than cow's milk protein, of course, because formula is cow's milk based. But if you do the environmental testing, you're going to get the baby like atopic to allergic to most of everything because they haven't had that chance to develop the antibodies to a lot of stuff yet. So, so lotion, cream, and ointments, which do we go for, right? Most of you know already, lotions have high water content and low oil content. So, most of them have ethyl alcohol in it. And then the creams are the ones that come in the jar, lower water content. In dermatology, we like, of course, the ointments will be your kind of emollient, kind of like that will kind of trap your water on the baby's skin better. But cream seems to work really good as well, not as greasy. Of course, cream's the ones that come in the jar. And I'm not endorsed by anybody, but Cetaphil, CeraVe, any kind of thing. But those do tend to be expensive for those of us that serve the lower income populations. They're not going to want to spend $17, $18 a jar to get those out for us. So there you have to look back at, again, your Vaseline probably. Ointments have your the best, again, to trap the waters. However, if you have a baby that's covered, that first baby that I show you, imagine Vaseline all over from, face all head to toe. How do you hold that baby, right? Or put the baby here, it's like, oh, what's left on my shoulder, right? So if parents don't mind that, that's okay. Just this past week, this Monday before I came here, we had a dermatology clinic. One of the moms said, patient was referred to us for atopic derm. And when, of course, the magic of waiting that long or the dermatology, baby cleared up before he got to see us. I walked in and she said, oh my God, I knew this is going to happen. By the time we get the appointment with you guys, the baby's going to be good. So I said, well, that's okay. I asked her, what are you doing? And she said, I used coconut oil. And then she's like, I didn't bathe him I only bathe him every 3 days or so. And that's the other debate that I hear out there going on around is, how often do you bathe that baby? So dermatology-wise, we don't say skip the bath or do this or do that. It's okay to bathe the baby every day, but the key point is you do it short, cool baths, that 5 minutes or less. In the past, when I first started out in dermatology, I don't know if anybody would remember, but they used to tell you to soak the baby until the fingers turn pruny, the skin, so that you're thinking the water will stay in there longer and more. Well, now it's short, cool baths, And yes, if you need to, you use the soap to the folds area, the diaper areas, you know, the neck, the axillary, the groins. That would be okay. And then get them out. And then the key is also, I think it's on there. I'm jumping ahead of myself. But the key is that you pat dry the skin and not let the mothers or fathers like dry them, rub them all clean and all that, and then put your emollients on or moisturizers on. Again, avoid the triggers. If you know that excessive bathing causes it, then don't do that. But a lot of times, it's not just excessive bathing as in like I'm bathing him 3 times a day, 2 times a day. They're scrubbing that kid down head to toe, okay? That's not gonna help. And not using the moisturizers as well. Low humidity environments. Emotional stress does have something to do with the breakouts of the atopic germs in the older people that we know of. Cirrhosis, the dry skin, overheating of the skin. We know that in the winter with the heaters coming on, that dries the skin a whole lot more, faster than other times. Again, the solvents, you know, those fabric softeners, Downies, don't let them pour those in. Wash the new clothes before they use them, and rinse twice. That's what I say too, is rinse twice and don't put any fabric softeners in there. Buy clothing that are 100% cottons and without labels, tags. Just have the ones that printed onto the neck. Now, compliance is a big, is going to tell you whether you're going to be successful with your treatment with the patients or not. A lot of times, compliance is a major hindrance to improvement. Short coup, as we said that. Unscented soaps, anything that doesn't smell good. What I say to the patients, parents, families is that sometimes less is more for the babies. So you don't need to go buy this, buy that, specific for children's even. Immediately when they get out of the bath, you want to leave the water. Even if anything else, just a few pat dries of the skin, and then right away emollients. Now, if they're given the topical steroids to use as well, you want to tell them they want to go ahead and put the medications first, and then apply the moisturizers or the emollients. Now, throughout the day, they have to use this. Now, people have said, well, what do you do with when you apply the topical steroids and they sting them and it burns them? So the trick to helping that is if you apply it if it's during the daytime and you have just not bathing the baby again, is you wash your hands really good, right? But don't dry your hand. Leave your hand with some water on, touch your wet hand to your baby's skin, and then lather them with the emollients or the moisturizer. That will introduce that water into the skin a little bit more, so that will help. And also decreases the sting a little bit as well. You've known of the wet therapy, correct? How many of you use wet therapies in your practice? Not so many, huh? Okay. How many of you have access to a dermatologist, like easy access? Wow, yeah. That's how it is in California too. The thing is, not too many dermatologists will practice seeing non-insured patients just because they don't get reimbursed a whole lot, and sad to say, but so there's not a lot of dermatologists at all that would see uninsured patients. Luckily we have 1 1/4. One other lady just volunteered to come help us too once in a while. But wet PJ wrap or wet therapy. Wet PJ wrap, what that is you wet the PJ, the baby's PJ, use again 100% cotton, wet it and wring it out some, not a lot, wring it out some, and then put another dry one on top of that baby and let the baby go to sleep overnight on that. During the time, all that hours over the night, if you can keep that on the baby, the next morning when you take off that wet PJ, you'll see a lot of sloughing coming out. Those dead skin's gonna come off. And that's gonna help the healing the baby skin a lot better. Now, be careful on how you recommend wet PJ therapy to, who you recommend that to. I learned my lesson the hard way because in the clinic that I work at, we serve a lot of Hispanic populations. But within the Hispanic populations, now I just learned this not too long ago, there was more than 18 subsets of languages, dialects within Spanish language itself. And that they live centrally where I live there. And you know, I was aware of a few that I had encountered, but one of the patients that I had taken care of in dermatology he was about 5 months old. He nearly died from atopic derm. Mom and dad are mixtecos. Those of you that don't know, mixtecos are the other subtype of Hispanic population from Mexico. So, but she did speak Spanish, and I asked her, do you read Spanish? And she said she did, but you know, again, culturally, when we recommended the wet PJ wrap therapy to her, her first comment at first was, if you didn't know this, the Hispanic populations, just like most of the Asian populations, you tell them stuff and they'll nod their head yes, even though they don't get it. But they don't want to offend you and say no to you. No, I didn't get it. No, I'm not going to do that, right? So they just nod their head. So with her, I knew what was going to happen. So I asked her, did you understand what I was telling you? And she said, yes, yes. I had her repeat back, you know, nursing assessment, right? Repeat back everything. So, okay, okay. Well, she went home, came back a week later. Well, the baby didn't get any better. What happened? Well, I didn't do the wet PJ wrap because it's the winter. You're going to give my kid pneumonia. I'm not going to do that. So, well, why didn't you tell me earlier? Well, I didn't think I want to, you know, tell you right in front that I wasn't going to do that. So, okay, well. So then we compromised. Okay, so okay, if you don't want to do it in the winter, how about we do it in this, you know, summer's coming soon. Can you do it in the summer? Can you try it a few nights per week? Now, if you can get them to do even 2 to 3 nights per week with this wet PJ wrap, if it's that extensive of the involvement in that baby, you will see a whole lot of improvement. So she agreed to it. So in the summer, she did it 3 nights per week. She came back, she was happy, smiling, we were happy. We said, what did you do? She said, I did the wet PJ wrap you told me to. It's like, okay, you finally did it. So, but that was the wet PJ therapy. Now, if you have a little bit of an area to cover, you could use the little ACE wrap thingy, you know, just wrap it around to the areas that you need to, and that would be okay. So when do you refer patients with atopic derm to dermatologists? So patients with refractory AD or atopic derm, those are the people that don't get better with all the supportive care that I've talked to you about and the first-line treatments of the topical steroids and all that stuff, right? So when nothing else you've done worked, then you can always refer them to us. So, but if by the time you get them to us, if you can get them to do all those things and ensure that parents comply with those treatments, you should have a whole lot more of success. What do you think this one is? Atopic derm? Not a trick question. It's this one. This is Eczema Herpaticum. I put this one in my kind of common, you know, it's not that common, but I just want to point it out to you that if not cared for properly, you can have it that bad. And babies die from Eczema Herpaticum. They can die. So Eczema Herpaticum is your herpes simplex virus, your HSV1 or 2. The baby's been exposed to that, and so they get this dissemination of the lesions. Now, there's not association between atopic derm and Eczema Herpaticum. It's not really well understood yet. So it's not to say that you have atopic derm, you can have, or you're going to have Eczema Herpaticum. Not really the case from the studies that had shown. Multiple host factors play a role in this. If you look at the lesions, that one, the first picture I show you, it's kind of more like it's already kind of drying up a little bit. They'll be vesicular, and they're like the same kind of lesions lining up the same pattern way. All these lesions have already kind of broken up and drying up. So you don't have to have atopic or severe or active eczema to get eczema herpaticum. You can just have a little cut or abnormal skin barrier functions can predispose you to eczema herpaticum. However, I know this sounds kind of contradicting each other, but patients with more severe, these people down the bottom there, Lung and Khan, Shaw, and Bernstein, 2014, 2013, they looked at these people and they say that patients with more severe atopic derm who also have history of food allergies or asthma, early onset of atopic derm, history of cutaneous staph or Molluscum Contagiosum infections are more prone to getting eczema herpaticum. So to a certain extent, you are more predisposed to it. So how do we diagnose eczema herpaticum? If all you've done for eczema treatment doesn't get the patient better, you've done all the baseline treatments, your antibiotics, your topical steroids, and your home supportive cares and all that stuff, and it's not getting better, or the patient is rapidly getting worse, and the lesions now have become painful, so you want to be suspicious of eczema herpaticum. So the gold standard to diagnosing eczema herpaticum is your viral culture. So we're going to do a viral culture. You're going to have widespread vesicles in the patients. So the lesions have similar shapes and size. And then again, the erosion is from the scratching that they do. They might have viremia, fever, malaise, or enlarged lymph nodes. So you can look into those, see if the patients have that. Now, with eczema herpaticum, you can have systemic complications from the eye standpoint. You can have cornea and conjunctival inflammation. That can lead to blindness in the children. And it can be also multi-organ involvement, meningitis, encephalitis, and even death. So with eczema herpaticum, there's about 6 to 10% mortality rate. So if we see that, well, how you get that with direct contact with the patient's secretions? That's how you transfer that. When you see that, usually the treatment, we always hospitalize the patient. Most of the times it's PO acyclovir, and then we help hydrate the patient. Usually they'll also need antibiotic therapy as well to help with the superficial infection that they got. And then the skincare emollients that we had talked about, we're going to strictly order that, actually put that on the order on the floor for the nurses to help put that on the patient as well. And you always have to refer them to ophthalmology because of the eye involvement that was talked about earlier. In the past, there were some worries about if you use topical corticosteroids, is that going to make the lesions a whole lot worse, make the HSV lesions, eczema herpaticum lesions worse? The people down the bottom there, Aronson, Shah, and Mohammed and Yan, in 2013, they looked at multi-center retrospective cohort study, looked at 1,331 cases there, and look at patients from 2 months to 17 years of age, admitting with diagnosis of eczema herpaticum. They looked at that, and there was no association between use of topical steroids making the disease worse or increasing the length of the stay. On the other hand, it's the use of systemic systemic therapy of the steroids that lengthens the length of the stay of the patient at the hospital. So you'll hear this. Our worst nightmare in dermatology is when we hear that children were seen in the ED for eczema or atopic derm flare-ups, and they get given steroid burst. We're like, oh no! And then because what happens is you can get a rebound effect easily from that. So they'll get better, yes, right? But then when you stop that corticosteroid, that systemic corticosteroid, that flare-up gets like even worse, just like twice that more. So think about before you actually put the patient on PO, corticosteroids, for treatments of that. Look into what else can you do, other stuff, anything else. Sometimes don't be hesitant to, if you have the superficial infection onto the lesions of body as well as a whole, that first baby there, if it's so bad, the very first beginning pictures that I show you, if it continues so bad and oozing out stuff, whippy lesions, I would put them on POs antibiotics, and you can do that for 14 days and just see them back again. Some people talk about bleach bath. You can. There's some recommendation that you can do that as well. Again, that's just to cleanse out the dead skins and the cells in the body, so of the baby. So that's okay to do that. But again, it's more of the supportive care of moisturizing and putting the emollients on, and be vigilant about that you're gonna get the patient better. You all know what this one is? Who said molluscum? Yeah, so if you look at it, classic description of molluscum is you have that dome shape with the umbilicated center, right? That's the keyword, umbilicated center. I don't have a pointer, but the one towards his nipple there, you can see that's kind of a little bit umbilicated center, a little dip into it, right? But if you look at a lot of molluscums, not all of them will have that kind of well-shaped umbilicated center for you. It doesn't have to have, all of them would not have that for you. It'll be, so how do you describe molluscum lesions? Molluscums are flesh-colored usually, like if your skin is light, it'll be light pinkish. It could be a little bit brownish, okay? But it's really firm in papules, usually not so large. It'll be papular size, and they're really firm. So they don't have to have all of the umbilicated centers, but yes, that's the classic part of it too. And then you see more of the redness, the erythema surrounding the lesions there. If they rub at it a lot, you can get the inflammation, or they scratch at it, they can get the inflammation there. See this one, you don't really see too much of the umbilicated center, but if you feel that lesion, it's going to feel firm in your fingertips. In the babies, you're going to see them more in the trunks, in the abdomen area. So those are really common areas to see. As they get a little bit older, more in the face, the extremities. So molluscum is like a cousin to the Warts virus. We usually explain to the parents that it's pox virus family. More exclusive disease of the children than the warts, because warts, you can get them as they get a little bit older as well. It's chronic and localized infection. Again, flesh-colored, dome-shaped papules anywhere in the body, except the soles of the feet and palms of the hand. You know why? If those lesions, this is how you distinguish between, is it Molluscum Contagiosum versus warts. If you see them on the soles, in the soles of the feet or the palms of the hands, those tend to be more of your wart. And then if molluscum, you're not going to see them in those areas. It's called demographic something. So with molluscum, human is the only known host, common disease of childhood. Again, may appear anywhere. So in the adolescence, if you see molluscum in adolescence, you might want to think STIs, sexually transmitted infections, contact sports, as in wrestling. They can get those. In immunosuppressed patients, you can get those, see those as well. In STIs or STDs, you can see them more in the groins, in the genitalia area, proximal thighs, lower abdomen. Now, in immunosuppressed patients, you're going to see these lesions are huge. They're not going to be papular anymore. They're going to be like really, really big and multiplying, really widespread. And molluscum doesn't have to be itchy. So some may come in and say, oh, but it itches. So it doesn't have to be, but some are. So skin-to-skin contact is how you sprayed it. And also by auto-inoculation. The kids go scratching. and then they go scratch here, so they put it anywhere else they scratch themselves with. So again, have them trim their fingernails short. Bath sponges and towels, don't share those. We don't recommend using those, what do you call them, foofies? Those fluffy balls that they use to scrub those babies down with. So don't use those because you harbor the viruses in there, and then when you use it again, your patient gets better. You use it again, that transfer those viruses back into them. Ever think about swimming pools, public swimming pools? Avoid those. Or use sleepers if you're on there, because if people have those lesions or anything else that come up, you can get those from those the walkways of the pool as well. Again, how do we diagnose them? Clinical presentation of it. Look at it, you can feel it, you can see it. What do we do for treatments for molluscums? So technically, if you can tell and convince the parents that you don't really need to do anything, right, with molluscums, we don't really have to do anything. It's self-limiting. So the thing is with parents is it's there, they look at them, they see them, and then they're like, it's spreading, it's more. It's okay, it'll spread, it'll get more before it gets a little bit better. But it can take between 6 to 9 months to get better, or sometimes even more. I'm jumping a little bit by myself. But if you need to, how many of you guys have liquid nitrogen in your clinics? Okay, that's quite a few, so that's good. So if you do, you can use liquid nitrogen to try to treat, and you're not going to have to treat all of the lesions. You choose to treat the few big ones. That's going to kind of trigger the body to respond, to trigger the response of the body to fight off the virus. So touch the ones, the larger few lesions on the body. You can do that every 2 to 4 weeks. We don't usually use cartilage because of the risk of bleeding as well as leaving the scar on the baby. So for all these years, I haven't seen none of my dermatologists, so I do that part. Now, what dermatologists have that us general practitioners don't have is the cantharidin or cantharone. How many of you have cantharone in your offices? Good. Okay, so a few. So for those of you that don't have cantharidin or cantharone, cantharone is not FDA approved in the States here, but it's been used in Europe country like a long, long time ago. It's beetle juice concentration, but you can't get it here from America, so you have to order it from Canada. Our dermatologist orders it from Canada. It's a blistering agent. So basically, you touch a little bit to the blister, to the lesion, it'll kind of trigger the blistering effect, and then they'll kind of slowly lift up the areas involved a little bit and trigger the inflammation process. Now, with cantharidin, we have high rates of parental satisfaction for the fact that it doesn't hurt the baby or the child while we treat them in the clinic, because they don't feel anything. You just kind of paint it on the lesion. Again, don't go over the areas that's not affected. They hurt when they get home, so you just warn the parents a little bit. He might not cry here, but when they get home, if he cries, this is why, okay? But it'll make them a little bit more red. Topical retinoids, not that much successful. And then imicamod, not effective at all. The new study, new things now is the KOH, potassium chloride. That one still needs a little bit more of a investigation because it's still pretty new in dermatology. It's a compound specials. They use a little bit of the other stuff into it. Again, most cases resolved by 6 to 9 months. In the rare cases, they go up to 5 years. So you know what this one is? Warts. So again, you can see that it's in the palms of the hands. So again, with self-inoculation, skin-to-skin contact, spontaneous remission within 2 years with 2/3 of the patients. So maceration or sites of trauma predispose patients to inoculation. So if you have a cut or something, a trauma to the skin, to the area, you are going to get more to that. Many, many different types of warts. We learned HPV has like more than 40 different types, right? So mostly seen on the fingers. and periuncle, the back of the hands, again. You can have like black dots or seeds and globules of it. Now the word is dermatoglyphics. It obscures the normal skin markings, as in the hands, the fingers, the palms. It obscures your markings. Again, by clinical appearance, you can see that. Now, the treatments, choice of therapy, again, you can do the cryotherapy gun or the liquid nitrogen again, depending on your age of the child. The cryotherapy gun, the spray gun, if you haven't used it, it comes out sounding really scary to the children. So you have to be careful. First, demonstrate how it sounds to them first. If you think they can hold on to it, I don't let them see what I'm doing, but I'll show them what it looks like, and I'll say, see, I usually spray myself to show them. But otherwise, you can use cantharidin as well. Now, with this one, you can use different types as well. I don't go all the way to excision. Laser treatment, we don't really have to do all. This is kind of like, even dermatologists don't usually go this far to that extent. So, but just those are some of the things that if you wanted to. Again, before you put the medication, soak it down, par it down a little bit, just so that the medication gets through to the lesion a little bit better. And you can do salicylic acid or TC, you can use that prep as well. Duct tape is has not proven to be that effective, for the fact that depending on where you are, the lesions are usually on the hands and the feet, right? So how do you tape those down? In kids, they're not going to stay, so again, not as effective. Again, avoiding scratching, nail filers, keep the warts dry, wear flip-flops at swimming pools or public places, no sharing of bath towels. So this is kind of same kind of recommendations for your molluscum family. When do you refer them to dermatologists? When it hurts, or it burns, it itches, or it bleeds, or if it's growing rapidly, you want to go ahead and refer them. Warts are on the genital areas of the face, or suspicion that the lesion is not wart. So that's when you want to refer to us. You've heard of him, right? All of you? No. This is a real case. He's Indonesian. He is referred to as Tree Man. In 2008, he was discovered by Americans here, and it was aired on like a whole bunch of Discovery channels as well, did the things on him. So he had a cut to his knee. He was in the forest, got a cut to his knee, and then the wart, got one wart, and then all of a sudden didn't get the treatment, and then later on and on and on. 20 years, that's how he got to that. So without treatments, the extremities branch out like branches of trees, and that's how it was. He's got some immunosuppressive stuff going on as well. The last time I heard, he's had like 3 surgical treatments, removals of the warts, like by 20, each time he had like 20 to 40 kilos of warts removed from him. But again, the next year it'll return because he's got some other stuff going on with him. But not so much of that. So you don't want to wait that long to refer to us. So of course, right? Hopefully not. But hopefully that I gave you some pointers enough to think about what you can do first before or during the time that you wait to refer the patient to us. And if the description on how you refer it on that referral will tell us, because I have to tease out the referrals. Just so many come into us. And I'm looking at the referrals. Most of them will come to us like suspicious looking rash. I'm like, okay, all rash are suspicious looking usually because we don't know what they are, right? So describe them. And then your moles, your nevi, look at yours, what the size are, what the shapes are, what are the demarcation of the color, the size, the shapes, what do they look like? If I can read your referral and kind of paint the picture of what the lesion is, you'll get in probably, I can decide if it's something sooner or later. So out of time, but if you guys have any other questions, I'll stay here a little bit. Thank you.